frequency, what you are looking for, the normal things and also the color Doppler. रिमेंबर जब फेस सपोर्ट, हाँ पहले तो बहुत डिबेट था कि ये एंटिटी एग्जिस्ट करती है नहीं करती है, बट नाउ एवरीवन नोज दैट लुटियल फेज डिफेक्ट, दिस एंटिटी डेफिनेटली एग्जिस्ट. And what are the causes of luteal phase defect? It is multifactorial. It is because of abnormal folliculogenesis, inadequate LH surge, inadequate secretion of the progesterone by corpus luteum, and sometimes aberrant end organ response by the endometrium. So I am not telling you all the theoretical part, I am just skipping and coming to the practical part. And what I am covering in this talk, is there any need for support in natural cycle IUI? What to give, when to give, what dose, and when to stop. So let us discuss these practical points. नेचुरल साइकिल IUI इंडिकेशंस हमने देख लिए हैं. अगर डोनर साइकिल है, सर्वाइकल फैक्टर है, माइल्ड टू मॉडरेट मेल फैक्टर है, यू आर नॉट स्टिमुलेटिंग, so you are not playing with the hormones, so there is no need to give luteal phase support in these cases because it will be unnecessary and it will only increase the cost. But if you are doing stimulated cycles, you have to see what happens when you are stimulating. Multiple follicles of different size, they ovulate at different times, which expand the fertilization window. Thus, both estradiol and progesterone is expected to be significantly higher. And these high concentrations may not only influence the receptivity of the endometrium, but may also cause luteal insufficiency and early luteolysis. So that is the reason we are giving luteal phase support when you are doing controlled ovarian hyperstimulation, that is COH. What are our options for luteal phase support? We have vaginal progesterone, intramuscular progesterone, oral dydrogesterone, and HCG. Vaginal progesterone, we have capsules, we have vaginal gel, and we have vaginal tablets. Now let us see which one you should prefer. This is again for the sake of completion of the presentation. HCG we don't use as a luteal phase support. So don't give HCG after you have done IUI. Progesterone is the preferred. Now you should choose oral, intramuscular or vaginal. When Dydro market में आया, it was flooded. हमारे पास भी बहुत सारे स्टडीज रखे थे that Dydro is non-inferior to progesterone. So you can use dydrogesterone for luteal phase support. There are various studies, but let us understand the pros and cons of each route. Now when it comes to oral progesterone, definitely as compared to vaginal, there is poor bioavailability due to rapid hepatic metabolism and it fails to induce the uniform secretory changes in the endometrium. And also your patient do complains of some sedative effect. So this is the problem with the oral. Vaginal, easy to administer, avoids first liver pass metabolism, no systemic side effects, higher endometrial tissue level despite low serum level due to first uterine pass effect, and similar pregnancy rate as intramuscular progesterone. However, your patient will complain of vaginal discharge. Some patient will complain of perineal irritation. So you have to counsel them about the discomfort. Intramuscular, now we are having aqueous based injections. Previously intramuscular oil based were very, very painful. We are not giving oil based injections. If your patient is very, very, say they are in love with injections. So you can give aqueous. And we are giving aqueous में 50, not 25. Give them 50 aqueous intramuscular. Dydro रोल है क्योंकि हमारे कई पेशेंट्स जॉइंट फैमिली में रहते हैं, पेरीफेरी से आते हैं, they are not comfortable with the vaginal administration, they find it messy, even educated patient they too take some objection. So in this case, oral preparation becomes their drug of choice. So oral, then Dydro. 10 मिलीग्राम का भी टैबलेट है, 20 का भी सस्टेन रिलीज आ गया है, 30 का भी सस्टेन रिलीज आ गया है टू इंक्रीज देयर कंप्लायंस. 20 is good enough dose, but if she is having higher BMI, do give them 30. GnRH agonist नया कंसेप्ट आया है एज अ luteal phase support. You can give them single dose triptorelin 0.1 milligram 6 days after ovulation, that is after your trigger, and 3 doses of lupride 1 milligram subcutaneous 6 days after ovulation. So this is the study I am just quoting. According to this meta-analysis, they are saying that oral ovulation cycle, there is no need to give the luteal phase support. But to be very frank, we all are giving. Even I am also giving. Even in letrozole cycles, I am giving luteal phase support. Gonadotrophins, it's a must. But oral ovulations, it's not must according to the studies. Now, once you have started, when you should stop? On the line, when the test becomes positive, when you see heartbeats, or you have done your NT scan at 11 to 13 weeks, depending on your confidence level, and any time you can stop the progesterone support. So any questions?